Hi, everyone. Welcome back to the podcast. Welcome all new listeners and welcome back to those who have heard my content in the past. If you want to know what's different about pro athlete rehab and what they don't teach you in CEU courses, you have to tune into this episode. Before I go on to the podcast, what's the latest and greatest? What's happening in my world? I'll tell you one thing. I have been consistent with my personal wellness routine. I've been doing daily saunas and daily cold plunges, so it's been great to be consistent with that, and just the effects on how that boosts my mood and just makes me feel so much better early in the morning. So that's been great on the personal side. On the family side, my wife is doing great. We're doing enjoying some time away, just relaxing and being a family. My kids are uh, they're off of school, so they're they are having the time of their life. They are literally asking, "What's the countdown to return to school?" So they can enjoy that time. This is their first like true summer off, so it's been great. But yeah, onto the podcast. What are we talking about, and why are we talking about pro athlete rehab? What is this about? And this comes from a conversation. This was a case that was brought up to me, and I want to share an actual case study and show you my framework on how I would approach this very unique case. And for those of you who work with elite athletes, high level athletes, community members, even pro athletes, this is a great foundation in how to change your approach to clinical care, and from your evaluation to your home exercise progressions and everything else in between. You'll find how this can help your practice within portions of the framework and then throughout the podcast. So let me share this case study so you can understand the context and what you would do differently. So we have a pro athlete who is about to hit one of the biggest competitions of their life in the next 4 weeks. So we have a 4 week timeline to be able to help this individual, and they have foot pain, and they're 4 weeks out from a big competition, and they are a sprinter. They are a jumper. And if you've never worked in the track and field world, when you manage these type of athletes who are multi-sport athletes, I think they're a pentathlete or a heptathlete, and you have to figure out, how do you get this person back to all these different sports or events without flaring up specific tissue? And this case was fantastic because it comes at a point where a clinician has to figure out what they're going to control, what they can and can't control, and ultimately, what would you do if you were the main person managing everything? Maybe they didn't have a coach, maybe they're a high school athlete and the coach doesn't know how to manage the injury, and they don't have an athletic trainer, they don't have a strength and conditioning coach. What do you do as the sole provider? Now, working in pro sports, you might have all the resources. Now, how are you collectively working with a team to ensure somebody's on track to make sure they meet certain marks or they can actually compete? So, this case has a an athlete with foot pain, and he is experiencing it with any form of impact. And that, if you don't know the specific events in a heptathlon, the majority of heel striking in any form or fashion will probably come off of a high jump or a 800-meter run, depending on your stride. But everything else, in terms of the other events, it's a 200-meter run as well, and that's going to be more forefoot based. So anything that is striking the outer portion of the heel is really going to be affected. So when you look at this person who comes into you and they say, I'm experiencing pain, and you're a physical therapist, you've been able to do this, in your sleep, you can manage heel pain. But the challenging part is they have to compete in 4 weeks, and they have to maintain peak physical condition leading up to those 4 weeks. And if you don't, they'll become deconditioned and they risk performing well at the event. So what do you do? How do you manage this person? So I'm going to outline a couple things. I wrote down a couple things, so I'll review them with you. But When you're managing a case like this, you have to compartmentalize. There's a rehab portion and there's a performance portion. And when you separate those two, you have to figure out what are you managing and how do they overlap. So if you're managing rehab, there's a couple things that make it easier for you to do that, and a couple things that you'll do. I wrote down a couple things here that say, you first have to figure out where their healing phase is, right? So let's assume this just happened, and you have 4 weeks out. So now you have somebody in acute injury pain, right? By 4 weeks out, you have to figure out what's the healing phases that you're going to be in. So for the first 6 to 7 days, you're in acute pain. And from 7 days to 21 days, you're in subacute. And from 21 to 28 days, you're in that proliferative phase where you actually now start to remodel, actually, and you're getting into more of that chronic condition phase. So when knowing all of this, you have to know, well, what would you do any different within those healing phases? So you have the context of healing phase. And now you have to add in, well, what are training modifications that you're going to do so that they don't flare up this in training? You can't say, well, let's just hold you off and don't train. For how long? For a week, for 2 weeks, for 3 weeks, for 4? What are you going to do? Are you adding any bracing? Is there any bracing that you would add in? Would you throw a boot? Or would you throw an ankle sleeve? What would you do for this individual? Another part is, what's the taping that's going to be applied? Are you going to apply any form of elastic tape or rigid tape? And for how long? For week 1, week 2, week 3? What are the modalities that you're going to use? Are you going to use, an ice cup? Are you going to use any form of iontophoresis or anything that you feel that is deemed necessary and that's supported by literature and your clinical practice? What's the direct treatment that you're going to do? Is it to the calf? Is it to the hips? Everything else that you call your special, like tools, right? Like your hands, and what is it that you're going to apply? And then lastly, what are the exercises that you're going to do? And I break them down into two pieces. That's primary and accessory. And when you are working with rehab, I highly recommend that you don't need more than 2 to 3 exercises, primary exercises that are really going to address the main root. So I'll give somebody 2 to 3 exercises that are primary and 2 to 3 that are accessory, and I'll break those down for you. But ultimately, you have to figure out, you have a 4 week timeline. Before you start going all the way down into this framework, you have to figure out what your plan is. What's the plan of care and what's going to happen from week to week? And this is the part that a lot of physical therapists struggle with. This is the part that requires a lot of planning before you go dive into designing the exercise, designing the tape job. You have to figure out at what week are you going to be doing what, and how do those overlap with what they're doing in training. So I always start with the healing phase first because that controls so much within their season. So if they're in acute phase, you can't really be aggressive with rehab. You really have to limit how much more tissue trauma that you're doing to the heel. So now you have to figure out, what are my training modifications? What am I doing for this individual? So if we know that this person has to compete in 4 weeks, what are you doing? And I brought this case to my team at Sports Performance, and I've shared this with numerous physical therapists that I mentor as well. And I thought this would benefit your clinical practice because this is something you're seeing. Maybe you don't have all the bells and whistles of, maybe you're not seeing the pro athlete, or you have all the access to whatever equipment that you want, but you are seeing these people. It's just in a different context. So if you're looking for training modifications, what do you do? So the first thing that you're going to consider is even a boot. And the reason why you would use a POTUS boot early is because if you're looking at a 4 week timeline, those first 2 weeks are the most critical to calm things down. The first 6 days are absolute importance. The second week is really where you don't want to flare things up. So if you're going to compete at week 4, you have to work backwards. At week 3, what are you doing? You're probably going to start to load that and probably introduce the 800 and probably the high jump. Or you can save it for the week of the event and only practice on those 2 events on the week. What you're not going to do is you're actually going to remove the stimulus, and you're not going to induce more trauma. So you're actually going to remove any form of heel striking at high intensity the first and second weeks, guaranteed. Now, the battle becomes once you're out of those first 2 weeks, when do you introduce high intensity again, or when do you induce more impact activities like plyometrics? What you have to do is you have to work with a coach, you have to work with the athletes and figure out how good or confident are they at these events. And if it's their strengths, then you can push it out to the very last week and know that they're going to do well. You're just not going to induce trauma, and you can put all your eggs in the basket of competition. Now, if it's not their strongest suit, you kind of have to introduce that at week 3. So week 1 and 2 are really your reduction in stimulus. So that's why I mentioned you would introduce a POTUS boot, because that would lower the risk of overall trauma. You'd have them in shoes at any given time. You'd have them in heel wedges. You'd have them in heel cups, anything to reduce the strain over the first 2 weeks. Now, when you start modifying training like this, the coach will obviously ask you, okay, so what can I do? And from that, you have to figure out, well, you have to understand the other portions of the sport. And in reality is, if the main trauma, the trigger to everything that they're doing is heel striking, they're allowed to do anything else that they want. That's fine. They can train. They just cannot do high intensity heel striking, which means I call them green and yellow and red lights. So from a red light standpoint, nothing to high impact heel contact, which is going to be 800 and high jump. Everything else is a green light. Anything that introduces any form of impact other than the high jump and the 800 is a yellow light. So you're really working on what's going to flare up this individual over time across a week with their ADLs, with their fitness, with their sport. So what you're doing is, on the red light side, you're saying nothing to training with 800 meters and high jump. On the yellow lights, you can say you can walk around in your daily life, but the thing that they have to be careful with is the volume of steps taken across a day. So all you're doing is removing volume, removing intensity, and allowing them to heal. Most pro athletes get hurt at practice because of high intensity, some form of high intensity. And what you're going to do on the back end, while they're training in season, they have to maintain some form of high intensity with their central nervous system to be able to perform at their best. So if they're trying to create high intensity with their central nervous system, you're going to control volume to the tissue at the rehab level, meaning allow them to train so they can keep high intensity. On the rehab side, you're going to keep volume low so there's no more tissue trauma. It's just an easy equation that you can understand as a clinician. You've really not considered, how do I separate performance and rehab? Oh, there's a big difference. But the term, when you're going to bridge the gap between rehab and performance, what if they're in season and hurt? Now you're actually not bridging the gap. You're actually creating a performance and rehab plan. So it's not a bridge, it's simultaneously happening. And clinicians who can understand this, and they can use both of those categories to lead their rehab, their projections, their plans, are the ones who are going to be successful. Why? There's 3 parties involved. You have the athlete, you have the coach, and you have the medical provider. And the medical provider sees their own stance, right? They're like, hey, we have to remove trauma. The coach says, hey, that's fine, but I need them to be able to perform. I need their central nervous system performing at their highest peak level. And the athlete is saying, I understand both of you. However, their mental status needs to remain high. So what you need to do is you need to say that you understand both sides, the rehab and the performance side, and tell them they can still train. On the rehab side is, we're going to take this under control. Here's your entire plan. We're going to go low volume from the beginning. We'll raise your intensity as you come into practice. And now the athlete can see both sides. They're like, okay, so I'm going to peak at the right exact time. And so you're not necessarily bridging that gap. You're being able to control both of them simultaneously while you get them back to sport. So when you take an approach like this, this is not something that's taught in CEU courses. It's not taught in continuing education or classes. And the reason is because when you have an opportunity to work with pro athletes, Rehab will only work to a certain portion or a certain part. It is your job as a clinician to collaborate. And when you are in continuing education course, it's about developing your skill, right? Like your like technical skill. And in order to maximize rehab and performance at the same time to manage pro athletes, you need to develop a different type of skill, which is your planning skill and your communication skill. And both of those have to be in line with what the athlete needs and wants, and what the coach and what the coach wants and needs. And you as a clinician are understanding both of these concepts. And if you were on my last podcast, I explained it's not your job to say no to these individuals. It's not like you can't compete. It's how do we get you to the best possible place so you can do this, so you can be able to participate in this thing at the highest possible level, given your current circumstances. And when you as a clinician can understand that, it's not about technical skills. Technical skill is great because that's how you're going to manage the pain within the first 2 weeks. But your ability to plan and map this whole concept out so that athlete can see it improves their mental state, improves their positivity, that they feel that they are going to even have a chance. That directly will improve their outcomes. And then you have a coach who is like, I need somebody to, to bridge this little portion over here, which I don't understand and I can't do it. It gives the coach confidence, which ultimately gives the athlete confidence. That's your job. So you have to combine your technical skill with your communication skill and your planning skills. And all of those come together to be able to help an athlete. And so when you are taking a step back, you're like, I'm a clinician, I work in an orthopedic practice, I work in a whatever setting that you do. And maybe you have direct access, maybe you don't, maybe work in a system that doesn't allow you, or maybe you see a lot of athletes that are, fresh off of an injury from the court or from the field straight into your clinic. And when you have these opportunities, this is where it matters most. And most physical therapists during these type of scenarios will ruin it by saying, let's just hold you out of practice. Let's not do that. We're just going to do a lot of volume of rehab and aggravate the tissue. That's not really what you're saying, but that's ultimately what you're going to do in the clinic. You're going to say, let's not do this at practice. You're going to reduce their total volume of stress or stimuli at practice, which is going to dampen their nervous system. And then you're going to do a lot of induction of trauma inside the clinic, and with your fancy tool or your modality or the new stretch or the new thing that you learned in a CEU course that only applies to somebody who's 6 weeks or more out of pain. And when you're doing this early on, you don't want to mess things up. And I tell you this so that when you get those athletes on your schedule, when you get more pro athletes, or the next time you do have a pro athlete on your schedule, that you're approaching it with a solid framework, and it gives you the best chance of maximizing your outcomes. So where do I learn all this? Where do I develop this? This is probably over the last decade working with pro athletes. It all started when I worked at the Olympic Training Center in Chula Vista, California. I was the healthcare provider as a physical therapist there, and I used to apply the traditional orthopedic approach to all my patients and athletes. I would, try and, get all the fancy exercises. I'd give them 27 exercises at 10 to 15 repetitions, increase their reps, increase their strength. And that worked in the off season. But when people were in season and you did that, you flared them up, you slowed down outcomes. And a lot of times the coach or the strength coach would come in and say, what happened? Why'd you flare them up? And it came to a point where I had a couple of flare-ups. I was very frustrated because my outcomes weren't there. I was like, I've learned everything in my residency. I've learned everything in my CEU courses. Why is this going wrong? Well, this is not what's going to be taught in a CEU course, because there's not a lot of opportunity to get exposure like this. And that's why I want to be able to share it, because if I've had that exposure, I know that there's a lot of clinicians like yourself out there who want that information, who want the outline. What do I do differently? What is it? And it's not the fancy exercise. It's not the great tape job. It's the approach. It's the plan. It's everything involved in getting that athlete seamlessly to that competition point without flaring it up. That's the biggest thing you have to outline. And I wanted to share the entire outline on how I approach it. So to start, as I mentioned, I look at what healing phase they're in. First of all, are they in season or out? This case is they're in season. They're 4 weeks out from the biggest competition. They're in the acute healing phase. They will be able to transition into a remodeling phase within 28 days. We know that. So healing phase first. Number two, what are the training modifications? meaning green, yellow, and red lights, they need to be doing both on the field, in the weight room, and in their daily life. So in this case, I'd put a boot on them for 2 weeks and then transition them out by increasing the volume of total daily steps on the third week, and then transition them to actual high jump and 800 meters on that fourth week. And what that does is it allows the tissue to calm down, and it gives them the best chance. So what you're doing is you're almost launching them or increasing intensity closest to the timeline where they're going to come, they're going to compete, which you might say, well, how do you know if they're going to be safe? Well, if you introduce intensity too soon, you risk flaring them up, and you risk an outcome that you could have saved. And this comes from a lot of mistakes that I've made early on. You don't aggravate it in those first 2 weeks, and then you figure out what's the remaining gap. So get them through the first 2 weeks, and then you bridge them into whatever it is. Now, the tricky part is if they have 3 weeks, that becomes very difficult because you only have 1 week to launch them back into sport. Now, if you have 6 weeks or 8 weeks or 10 weeks, now that's easy. That's like, we can do that with our eyes closed. So healing phase first, training modifications in the weight room, on the field or on the court, and in their daily life. Healing phase, training modifications. Number 2 or number 3 is, what bracing do they need? Number 4, what taping do they need? Number 5, what's the modality that you're going to include? And if you're an anti-modality, it'll be tough for you to manage acute injuries. That might work for chronic pain or whatever it is, but in the acute healing phase, you have to figure out what other tools can I gain to give me 2% more improvement, 8%, 12%, anything I can do to improve healing. Number 5 is direct treatment. So all the manual work, whatever, dry needling, whatever it is, whatever your flair is, whatever you decide. You're the main chef, you're the cook. You can put whatever spices you want. You can figure that out. And then lastly, which is where physical therapists go first, is the exercise. The exercise is driven by the healing phase, divided by the training modifications, the bracing, the taping, how they're overlapping with training, and then you get to decide how many total exercises and what are the ones I'm going to select. And like I said, you only need 2 to 3 primaries, and you can use 2 to 3 accessories if you need. And what that does is helps formulate the plan of care, so that way the athlete knows exactly what's ahead, and the coach knows exactly what is ahead. And you, as a clinician, can step back and say, I've built this roadmap. Now I just need to make adjustments. It all starts by first creating that roadmap. You have to be able to do that. And, I call it the roadmap. It can be a plan of care, whatever it is that you want to call it. Number 2, you then have to communicate that to both the athlete and the coach. They now know what is ahead. And the last part is, now you have to make adjustments. And how do you make adjustments? How often? And honestly, it is on a day-to-day, multiple times a week, making small adjustments and just fine tuning. You're not making huge adjustments to those dials or the categories. All you're trying to do is, what am I pushing a little bit to the left? What am I pushing a little bit to the right? What's the thing that I need to do? Was it too many steps? Did you have too many reps at the high jump? What do you need to do to make sure that they still get the reps in, but maybe you have to lower the volume, or maybe you can increase intensity as you do that. And so it's just learning how to play with tissue trauma. That's all it is, right? Like, tissue trauma is everything. Stress and strain over time is what creates pain. And so now when you're managing pain and they're going to be inducing more tissue trauma, you have to play with, well, what are the other things that I can reduce the overall load across a week? So for instance, during the week that they would be doing 800 meter or high jump, I have to reduce the total amount of stress that they're doing in their total daily steps. So I would say you can put the boot back on for daily activities. You can use crutches. You can use a scooter. You can use whatever it is. So that way all your eggs aren't in the most important baskets. And this is all you're doing in the pro world. You're just putting different pieces together, and there's no ideal. There's no ideal. You always have short timelines. You have scenarios where it's not perfect, not ideal. Doesn't matter. Your job is to help them get there with the lowest risk of re-injury. And when you combine the last few podcasts with everything I've done, your job is to facilitate. You're a healthcare provider. Stop thinking of yourself as a physical therapist. You're a healthcare provider who happens to know musculoskeletal care and injury, but ultimately you're trying to, help with their mental state. You're trying to help with their general nutrition. You're trying to help with acute injuries. You're trying to help with soft tissue, bones. I mean, you're doing the whole gamut. And your job during this time is to figure out, what help do you need right now? What's my timeline? How fast? What are the modifications that I can give you? And then lastly, what things can you do to improve strength to offload this, which is your exercises? So I want you to reframe how you approach any of your athletes, and they don't have to be pro athletes. They can be community members. They can be high schoolers. And this is the approach that I take and have my team take with every single person, whether it's community member, pro athlete, anybody it is. And what that allows you to do is create a comprehensive framework to manage athletes at any given time. And maybe you don't call them athletes. Maybe they're orthopedic patients who happen to want to be more active. And to me, that's an athlete, somebody who just wants to be more active and induce more tissue trauma to their body. That's really what an athlete is, right? So this should help in your clinical approach in your practice. The whole goal is that you can manage anybody that comes in your clinic, anytime, any type of trauma, any timeline, and that gives you so much power to be able to manage anybody with any form of injury. And like I said, you won't find a lot of this content in a CEU course because the exposure dictates the framework. And learning this has been profound in the people that I see. And what you could do is start by using the outline to put you in a position to start thinking differently. Like, how do I approach this athlete with that same framework? Write them down, put it into an initial evaluation. It gives you that framework. It's a good starting place. And then you can figure out, how you want to maneuver or make adjustments as you go. So if you love these cases, I don't know if you can tell through the podcast or if you watch this on YouTube, I love what I do. I absolutely love it. And, I think working through cases is probably one of my top things to do. I enjoy mapping it on a whiteboard and just seeing what's possible. Where would I maneuver? Where would I change this? What intensity can I go? And that gives me so much clarity. And, it's the biggest thing that I do. When everybody asks me, hey, what exercise should I do? What would you do in this case? I put it on paper, and it shows me what's possible and what's not. And you as a clinician, one of the things that you do is you go off of, whatever you've been exposed to, what your memory tells you, right? And you're like, I don't know if that's possible. One of the things you can do, just write it down, use a framework, map it out. What's the week by week? How is this going to even be possible? When you look at it, you're like, actually, this can be possible. They'll be able to get in there maybe 70, 80% better, but not 100%. And it's possible. And to me, possible is better than not competing. So if you enjoy cases like this, and this is something that you want to get better at, you want to be able to refine, I need you inside my Sports PT Academy. I've had a couple requests on asking what it is, what it entails. And the best thing I can tell you is, if you are a physical therapist and you want mentorship, you want clinical support, but not necessarily in the form of a CEU course, everybody can do that. You really want to get your specific questions answered. Where should I go next? What's the thing I'm missing? If I'm good at this portion of rehab, I've done McKenzie, I've done these things. What should I do next? What am I missing? Or I feel like my outcomes are stuck. I can do this, or I don't have more athletes on my schedule. I want more, or I want pro athlete. I have athletes on my schedule, but I want pro athletes. All those things, if those are the questions that you're asking yourself and you feel stuck, that's who it's perfect for. That is the person who I want inside my academy. Somebody who is motivated, somebody who wants to challenge themselves, somebody who is introspective and they want to improve their clinical practice and they haven't been able to find it. Even if you've done a residency, even if you've not done a residency, you have all the credentials in the world, you still have clinical reasoning that you have to work through. And if you're looking for a resource that's easy to use, practical, based on years of experience and evidence and everything to help athletes at the highest level, this is for you. And my Sports PT Academy is clinicians meeting virtually every single month and going over clinical cases, going through your own personal questions, diving in, asking. And it happens, currently happens once a month. And we're just going through, everybody has homework assignments before they come in, and they tell me, what's the thing that is going to make the biggest difference over the month? Where are you stuck? What's the biggest thing that you need? What are you working on? Knees, shoulders, backs, and that helps you kind of figure out what your next step is professionally. And that's ultimately what you're trying to solve. What's next for you? So if that's perfect for you, let me know. Send me an email, drchris@drchrisgarcia.com. As I mentioned, I have 4 slots opening up in July. I'd love to have you inside the group. If it's not the time for you, great. It's not a problem. You can join at any given time. And I'm excited to see you inside the group at some point. If the academy is not good for you, consider taking my Management of the Barbell Athlete course, October 28th and 29th of 2023. That's going to be virtual and in person in San Diego. And it is focusing on barbell athletes, CrossFitters, weightlifters, anybody that touches a barbell. If you want to learn how to master those mechanics, or, figure out progressions, and you've maybe never touched a barbell, or you're an expert and you want to refine, or somewhere in between, it's going to be perfect for you. So other than that, I hope you guys are doing incredible, and I will see you guys on the next episode. Take care.